So thank you so much, Margaret, for setting the stage and for talking about what has happened around mental health in Canada during the pandemic. I think we've all felt these shifts, and it's so helpful for you to provide information and put numbers to what I think we've all been experiencing on some level. I'm going to be speaking to intersecting epidemics in Western Canada, specifically around COVID-19, around the opioid overdose epidemic, also mental health, and a little bit of other things that we should be not losing sight of. And I hope also to touch base on potential multi-sectoral responses and how we should be thinking about responses to multiple intersecting epidemics that we're currently witnessing across Western Canada. So I'm briefly just going to acknowledge that I am coming to you from the unceded ancestral territories of the Coast Salish peoples, including the Musqueam, the Squamish, and Tsleil-Waututh. And what you're looking at right now is a picture from a memorial way back in 2017, where things were already quite bad in terms of the overdose epidemic in British Columbia, but the worst was yet to come. We really didn't know what was happening, and each of those stakes represents a life lost between January of 2015 and September of 2017. This is often the face of what we think about when we think about the overdose epidemic. So this is someone who has gone down in an alleyway in downtown Vancouver and is being responded to in a particular way. But as we have learned, it is not something that is concentrated in Vancouver's downtown east side or in inner city areas, in municipal communities across the country. It is something that we are seeing in rural and urban spaces across Western Canada. So what you're looking at is the illicit drug toxicity death rates by health service delivery area in British Columbia in 2020 and 2021. And I show you this just to illustrate that it is a provincial problem in BC, like it is a provincial problem in Alberta and Saskatchewan and Manitoba. And it has gotten so bad that in April of this year, the BC Centers for Disease Control had to change the scale. So you can see in the middle, there's the scale, and the highest rates are in that dark brown and the lowest rates are in the sort of light yellow. And it used to only go up to 30, and we had to change that because the entire province was dark brown. And so we're constantly having to shift our metric of how we're understanding the magnitude of this problem. This was what was happening in 2019 before the pandemic. And in 2019, we actually saw overdose rates go down from 2018 slightly. And so there was much cause for optimism. We thought that what we were doing was working. And then, of course, COVID-19 hit. This is what the map looks like for the first 9 months of 2020. We don't have data beyond that. There isn't a map that goes beyond that. And we don't have data that goes beyond that from the federal government at this point, but you can see already that in the first 9 months, things were already way, way worse than they were in 2019. I've pulled the data that is available, and this again only goes to the end of September of 2020. These are the numbers of people who lost their lives to opioid-related deaths in Canada, in the sort of dark gray, but I've pulled out the information for each of the provinces. So British Columbia in blue, Alberta in red, Saskatchewan in yellow, Manitoba in green. But I think it's really important not to just be thinking about absolute numbers of lives lost here. I think it is much more informative to think about the rate. And the rate is often measured in the number of deaths per 100,000 people. And so these are the rates of death from 2016 to the first 9 months of 2020. And we see, again, there was a slight decrease in 2019, but that rates are really, really high. What we're seeing is way worse, for example, than what we saw at the height of the HIV epidemic. And so these are numbers that are very alarming. I also ask you to remember that 33.5 that British Columbia was at in the first 9 months of 2020. Just hang on to that number as a point of reference for the next slide. So what's happened in 2021? It's worse than 2020 so far by a lot. So these are the numbers for British Columbia. This is the pattern since 1995. And what you can see is That line shows the anticipated rate of death per 100,000 people in the population. And we are on pace to far exceed what happened in 2020, which was already the worst year on record. In April of 2021, there were 176 suspected deaths, the largest ever recorded in the month of April, and a 43% increase over April of 2020. In Alberta, this is the monitoring data from the Alberta government. We similarly saw during the first 2 months of 2021 a surge that was 153% higher than January and February of 2020. In Saskatchewan, we are seeing a similar pattern. I note that those yellow suspected deaths almost always become blue confirmed deaths. And this is why I wanted you to remember that number, that 33 number for BC's rate in 2020. If Saskatchewan's current trends hold, they will be at a rate of 31.9 per 100,000 residents this year. This is unfathomable. And when we look to Manitoba, one of the things that you will discover as a theme for Manitoba in this presentation is that data is pretty hard to come by. I was able to identify that the data from 2020, where 372 people lost their lives to overdose in the province, but I wasn't actually able to find any data about 2021 at all. And I just want to emphasize that we are really hard pressed to respond to things that we aren't understanding and aren't tracking. So this lack of data is quite alarming. And I know community organizations in municipal spaces in Manitoba are really sounding the alarm, but the provincial government isn't really responding with the kinds of monitoring and responses that we would hope to see. I also want to talk a little bit about how drug poisoning intersects with mental health. And I use drug poisoning and overdose somewhat interchangeably. I'm trying to move much more towards the language of drug poisoning, because what we are talking about is a toxic drug supply that is poisoning people. And my team over the last couple of years has done a systematic review led by a postdoctoral student of mine on mental health and opioid overdose, both fatal and non-fatal. And what we found is that when you break things down by type of mental health disorder, there does seem to be a relationship, a positive relationship, in that if people have mental health challenges, they also seem to have higher risk of both non-fatal and fatal drug poisoning. And we also found that the relationship is very complex from a directional perspective. Do people develop mental health challenges because of their substance use, or are people responding to mental health challenges with substance use? It's a really difficult puzzle to disentangle. We're going to revisit this a little bit later on when I talk a little bit more about multisectoral responses. So I've given a bit of an epidemiologic snapshot of what's going on in Western Canada. And I want to offer sort of two key considerations in how we should think about what is going on with the drug poisoning epidemic. The first is that fatal illicit drug poisoning is a really low bar. We shouldn't really be thinking just about preventing death. And that's because the consequences of non-fatal poisoning are severe and chronic and widespread. And we've seen significant increases in opioid hospitalizations in particular. I've listed some of the drug poisoning morbidity that we keep our eye on there for information. And it's really important to know that emergency responders in Canada in the first 9 months of last year responded to over 20,000 drug poisoning calls. Again, these are numbers that are pretty unfathomable, and we shouldn't really be thinking about just preventing death. We should be thinking about preventing drug poisoning to begin with in non-fatal, for both non-fatal and non-fatal outcomes, or non-fatal and fatal outcomes, excuse me. The other consideration that I really ask people to hang on to is that drug poisoning is not affecting all groups equally. So what you're looking at on the left is an infographic that was published last month by the First Nations Health Authority in British Columbia. And it really emphasizes the degree to which this is being borne disproportionately by First Nations communities in BC. We know that most poisoning deaths occur among men and young men and people who are living in poverty. And while most provinces don't collect data by ethnicity or socioeconomic status, where that data is available, as I mentioned, Indigenous populations are disproportionately affected, especially Indigenous women. And one of the things that we should really be thinking about is not about individuals and individual risk behavior. We should be really thinking about the degree to which our systems, our social systems, our community systems, our government systems create, through their policies, gender differences in poisoning risk, how the effects of racism on how people access care has adverse consequences for their poisoning risk, and that people are faced with inadequate and underfunded social and health services. And so we really need to be thinking about this from a health equity perspective about which populations are being affected, which populations are being underserved in terms of our efforts to prevent drug poisoning. So that's sort of the first section of my talk. I want to give everyone just a moment to take a breath because it's a lot of information and it is not good news at all. So things were bad already. After COVID, they are getting worse. And I'm going to spend the next part of my talk really introducing the idea of a syndemic. And so this is a term that for people who work in health, you will likely know this already, but it's an important one for people who don't work inside health to start to think about how we are managing multiple fronts in physical and mental health simultaneously. And so a syndemic is what happens when you have the co-occurrence of multiple epidemics at the same time that interact and worsen the effect of one another. And so I've identified here substance use, COVID-19, violence, adverse mental health. I'm not going to talk about violence or adverse mental health so much because Margaret gave us a great snapshot already about that. And violence is a little bit outside the scope of my talk for today. But we are seeing data that shows how these epidemics are reinforcing each other through the social factors that create the conditions that make people more likely to experience these things. And so what happened during COVID-19? So what we know is that people were at increased risk of severe COVID-19 illness if they had a drug poisoning history. They were more likely, for example, to have the 4 conditions that are known to increase the likelihood of severe COVID-19 illness. So that's the first piece to think about. The second is that there was increased COVID-19 illness among people with substance use disorder. This research comes from the US, but what was indicated by the study that was led by Nora Volkov was that people with an opioid use diagnosis were 10 times more likely to have COVID-19. And that is true for almost all substances for which we have use disorder criteria in the DSM. So that's the second piece. The third, and I think everyone has direct experience with this in this room, is that there were reduced or suspended social and health services. So services had to reconfigure to distance supports. Some were unable to provide the kinds of services that they had been providing because of what was going on with the pandemic. And that often removes a source of stability for people, which increases stress, leading to potentially higher risk of mental health challenges and or substance use. So that's the third piece. Fourth is that elevated stressors often increased substance use at a time when there was lower treatment access. And this is an article that came out in the New York Times late last year, but it really spoke to how substance use has increased during the pandemic, often as a response to increased stressors and increased challenges for mental health, and access to treatment is significantly lower. And it's important to remember that a lot of treatment and recovery for substance use happens in social settings that support people's healing processes, and that COVID-19 has conspired against that. Another piece to think about is all of the public health directives and physical distancing measures that we have all had to contend with over the last year, more than the last year at this point. It is very difficult to engage in physical distancing or to adhere to public health directives if you are socioeconomically marginalized. And that includes having timely access to accurate information, access to personal protective equipment, hand washing facilities. I mean, it's very difficult to shelter in place or to stay at home if you are homeless. In addition to that, people were more likely to use drugs alone. And that, before the pandemic and during the pandemic, has been documented as one of the most significant risks for fatal drug poisoning. And so for physical distancing purposes, on top of all of that, people use drugs, often avoided using available services. And so what we see is this real configuration of higher vulnerability, elevated stress, elevated substance use, lower access to services, and public health directives that were really important for COVID-19 management, but really not good for substance use disorder management. And then you add to that rapid changes to the drug supply. And we already knew that the drug supply was toxic before COVID-19. And with closed borders and interrupted supply chains, the drug supply has become more toxic. And this has involved the devaluation and decreased production of drug crops, the increase of synthetic production, and increase of domestic production. And so we've seen, for example, we already knew that there was a lot of fentanyl in the drug supply. What we're seeing now is also a lot of synthetic benzodiazepines in what is being sold on the street as an opioid. And so we know that that is increasing people's overdose risk as well. And we see this in coroners' toxicology reports. So from people's autopsies, we're seeing elevated rates of extreme concentrations of fentanyl in those autopsy reports. And so when we think about what has happened around mental health and COVID-19 and substance use, it is this complex intersection of people and infectious disease and stressors and drug markets and socioeconomic and institutional environments and public health directives and broader public policy. And it has really created the perfect storm, and we are now bearing the brunt of what is happening as a result. So again, I'm going to give us a moment to take a breath and have just a quick pause. And for the next portion and the final portion of my talk, I'm really going to focus on solutions and what's been done and what's being done and how we should be thinking about things moving forward. So what was in place before COVID-19 hit were a lot of different measures. There were a lot of really wonderful concerted efforts in trying to address substance use, risk of non-fatal and fatal drug poisoning, et cetera. And what you're looking at here is a map of supervised consumption sites and overdose prevention sites in Western Canada. And I like to think of this as a bit of a proxy for the concentration of services across the provinces, but it's just one kind of service, and really want to recognize that there are a lot of others as well. But you'll notice that there is not an equal distribution of these services across the 4 Western provinces. In particular, Saskatchewan and Manitoba really are not at the same place as British Columbia or Alberta in terms of the scope of services or the coverage of services that are being offered. And that's in part because in previous years, the need was potentially less extreme. But as we saw from the data, that need is absolutely there across all 4 provinces. I'd also add that in Edmonton and Calgary, there have been recent announcements of closures to their supervised consumption sites by the provincial government. And so that map is also changing. On top of supervised consumption, there are a lot of innovations that have happened in this sphere that in 2019, we were thinking, okay, we're starting to make a little bit of progress here. That includes the distribution of naloxone that can reverse the effects of an overdose. Innovative sort of treatment regimens and guidelines that were developed in BC, but then adopted nationally for using different approaches to the treatment of opioid use disorder. And what you see in the bottom right-hand corner is a drug testing machine. And so there's also the ability for people to have a little bit more information about what is in the drugs that they're using. During COVID-19, there were some responses that I would argue were critically important, the Canada Emergency Response Benefit being one of them. And there have been politicians that have pointed to the CERB as being responsible for the opioid surge and the overdose surge, one of the things that I would say is that I'm currently looking at that data with the team, and we aren't really seeing evidence that the CERB was responsible for that overdose surge. And so we should not be pointing at the money that people need in order to support their well-being. We should be pointing at the drugs that are poisoning them. There have been other measures that have been undertaken by advocacy organizations, by community. There have been sort of depenalization efforts at the federal government. And at the bottom, and I'll speak to this a little bit more in a second, what are known as the risk mitigation guidelines in BC, which is a first step towards providing a safe supply. But one of the things that we know is that it's been insufficient in terms of a response, it's been uneven, and it's been highly politicized. And so in BC, we are at a place where the provincial government is proposing the decriminalization of small amounts of drugs for possession and personal use. While in Alberta, we are seeing the closure of harm reduction services. In Saskatchewan, we're seeing sort of a mixed response where we're seeing a relaxing of COVID guidelines, of sort of mask requirements. They'll be the first province in the country to relax their mask requirements, alongside regional or municipal efforts to support harm reduction. And again, in Manitoba, very difficult to find a lot of public information about the scope of the response, about what is happening on the ground in Manitoba. I'm going to speak for a moment about decriminalization and safe supply, in part because these two initiatives have started to take up a lot of bandwidth in the media and in the public imagination about what our response should be. And there is a lot of potential for what decriminalization and safe supply could bring. But of course, the challenge is often in implementation, and the devil's a bit in the details here. I'm going to talk about each in turn. First, the safe supply guidelines were developed really, really quickly. And I think if the people who were at the heart of that development, if they had them to do over again, they might have done them a little bit differently. It is strictly a medical model. And while there have been non-medical models such as heroin compassion clubs move forward, the shift that's required to understand how to implement safe supply is really challenging, because it is a fundamentally different approach to illicit drugs than what we've worked with for the last 150 years, essentially. And what we know is that there have been a lot of barriers identified to the rollout of safe supply and alternative distribution programs, that the rollout was particularly bumpy, and that new efforts such as having vending machines, the federal government in the last budget actually included $3.5 million to support the distribution of opioid vending machines across the country. It's a really challenging thing to figure out how to do this in effective ways, how to reach people outside of urban centers, et cetera. And so there's a real challenge in how to roll all of this out. Similarly, with decriminalization, the idea here is that you start to decriminalize people so that they are less stigmatized, more likely to seek help, et cetera. And what you're seeing is a screenshot of the submission that the City of Vancouver made to Health Canada in the last couple of weeks, asking for certain amounts of drugs to be decriminalized, asking for an exemption to Section 56 of the Controlled Drugs and Substances Act to allow for personal possession. The challenge, of course, with what has happened with decriminalization is that it has been absolutely panned by advocates and scholars, myself included. And so in efforts to make this evidence-based, there were a group of scholars at the BC Centre on Substance Use who provided data to the city and made recommendations around what thresholds would be appropriate. And the decision that was made did not reflect the data, it did not reflect the recommendations, and the decision was made without consultation with people who have lived experience. And so because of that, and because the decision was predominantly driven by the Vancouver Police Department, what we're looking at now is a proposed model that has the potential to produce more harm rather than less. And you can see the quote there, the Prime Minister saying decriminalization of drugs is not a silver bullet for the overdose crisis. Absolutely, it is not. The decriminalization will do absolutely nothing to affect the toxicity of the drug supply that we know is at the heart of the problem. And so it is, again, something that in its implementation is gearing up for a really challenging run. So what I would offer as a potential alternative, or actually, I don't want to frame it as an alternative, I'd say as a complementary approach, is to think about how to prevent fatal and non-fatal drug poisoning to begin with. And in order to do that, we need to be thinking about how drug use intersects with socioeconomic conditions. And I'm conscious of time, so I'm not going to go too far into this, but really just want to say that we know that there is a really close relationship between people's material security, how they make their income, and their drug use behavior and drug-related outcomes. And in research that I've been conducting over the last 15 years, we've really understood how people who use drugs have lower labor market outcomes or suboptimal labor market outcomes, but that there are health impacts linked to the suboptimal labor market outcomes independently of their substance use patterns. And part of that is because people who are excluded from the labor market rely on high-risk income generation that produces more health harm. And so on top of all of that, my team has looked at the relationship between socioeconomic marginalization and overdose. And what we found is that the research in this area is really lacking. There's very little that explicitly focuses on that relationship, but among the research that does exist, we see that it is as you would expect it to be. People who have poor living conditions have higher likelihood of opioid-related overdose. And so we know that this is a potential area for intervention that has really been underemphasized in the public imagination, in media, by research, et cetera. I'd also ask people to start thinking about how drug poisoning intersects with social and economic policy. And what you're looking at here is a graph that shows the average number of deaths per day by Income Assistance Week. And so what that means is that the lighter area at the bottom are the average deaths per day in British Columbia over the last 4.5 years on non-payment weeks, on weeks where people were not paid their income assistance. And the dark blue above that is the additional average number of deaths per day that we see during income assistance payment weeks. And we know that income assistance payments are critically important in mitigating the harms from poverty that people who use drugs experience. But we also know that synchronizing those payments magnifies individual and social signals for increased use that puts people at elevated risk for drug poisoning. And so in order to see if we could do something about that, over the last several years, I've conducted an experiment that looks at what happens when you desynchronize people's payments and pay them in smaller, more frequent amounts. And it is a complex thing to do first it's complex to implement, but the results are also really complex in that our study participants decreased their drug use around payment days, both their individual payment days and the government payment day, by a significant amount. But being separated out from the rest of the system exposed them to other harms. And so we're currently working with data right now that hasn't yet been published, but what we're seeing is increases in other harms. So we had the desired effect on drug use, but what we're seeing is that there are other harms that increased because people were separated out from that synchronized system. And so I say all of this to say that it's important to be ready for unexpected impacts, because our reforms never function exactly the way as we envision them. And so I'm going to close now with 3 key points and 2 imperatives that I would like to pass along to people who are working in the philanthropic community and the community sector and the caring economy, as Margaret so eloquently talked about in her talk. The first is that we need to be thinking upstream and midstream. We need to be thinking about the role of social conditions in mental health and drug poisoning risk. We know that community-based health and social services can have a large and meaningful impact. And I, to anyone who will listen, am talking about how social policy is health policy and social policy is drug policy. We really need to be thinking about the conditions that put people at risk. And so I think there's a significant role for the philanthropic community to play. I know one of your hub's projects is really focused on linking with the United Way and the services that the United supports. I also think we should be thinking about bricks and walls. There is no single silver bullet solution. Harm reduction doesn't get us there. Decriminalization doesn't get us there. Recovery and abstinence-based treatment doesn't get us there. Safe supply doesn't get us there. Yeah. People are individuals and have varied responses, and it's really important to think through what is going to work in a particular circumstance. And so there is a need for mutually supportive intervention across community, health, and government organizations. Third, I think it's really important not to wait for government, but to not let government off the hook. So, for example, this story came out in Manitoba last week, where the chief administrative officer in Winnipeg essentially said supervised consumption sites can operate whether or not the province approves them. And we know that government often responds to things that they can see being effective, and that is what happened in Vancouver. Insite and other supervised consumption sites were built long before the federal government provided the exemption that allowed for its operation. Often we need to see community take initiative because they often have a better sense of the how of things rather than a government official sort of trying to conceptualize what it would look like on the ground. And so while there is need for huge public investment, we know that ideology and political expedience, as we've seen with supervised consumption site closures in Alberta and with the decriminalization process in British Columbia, it can really obscure evidence-based best practice across the political spectrum. So I'm going to offer two imperatives moving forward. The first is an imperative around equity-based responses. As COVID has made painfully clear for all of us, societal level shocks to our system don't affect everyone equally. We know this. What is less commonly understood is that interventions and innovations are also generally not accessed equally unless they're targeted really well. And so because they're not accessed equally, they can counterintuitively increase rather than decrease inequality, because the people who need the services most are the ones that experience the most barriers in trying to access them. The third thing to remember is that equity-based responses are context and population specific. And so they need to be accommodating social identity, social position, and geographic and political location in all cases in order to be effective. And I put a picture of the urban-rural divide there because I think that is something in Canada that we don't put enough emphasis on. The degree to which people living in rural communities have access to the services that people living in urban spaces, that divide is just, it is a really important gap that is going to have severe consequences moving forward. The last imperative that I want to add is that it is absolutely crucial to have the meaningful involvement of people with lived and living experience in the interventions that are put forward. They have knowledge about how things will play out so much more and at such a much more advanced level and in a real-time way. And so incorporating their wisdom and their knowledge and their experiential their experience is just critically important. I am going to leave it there. I want to thank you for your attention and consideration. Look forward to questions, and I also wish you all the best of luck for a successful conference. Thanks very much.